Good afternoon. This is Nancy Duncan from Under the Hood, podcast that covers all things private practice audiology related, the good, the bad, and the wonderful things that people are out there doing across the country and the globe. So today I have the pleasure of being with Dr. Heidi Hill from Hearing Health Clinic in Osseo, Minnesota. So welcome, Heidi.
Thank you. Thanks for having me, Nancy.
So tell me a little bit about yourself and your clinic. Let's get started with that.
Oh gosh. So I bought my practice in 2007 at the start of a recession. So it's been a journey and
Did it always?
yeah, in a lot of ways. It's a small practice. It's mostly been just me as the audiologist, but I now have another audiologist who's come on with me. So that's really exciting to be expanding there. I've been practicing for a really long time. Still practicing, still trying to figure things out.
Yeah.
Always looking to grow and learn.
And I think that's one thing a lot of maybe new grads forget, because I'm probably around the same age as yourself, that it's always practice, because you can always be better than you were the day before. And there's always so many new things to learn. So it's never, oh, I'm done with school, I'm done. I wish.
Don't you think that that's like a really big misconception that I think audiologists have coming out of school? I know it was for me.
Yeah.
Like, I'm done. I've put my time in. I've got the title. I've earned this, and we're working with people.
Right.
It never ends.
And I remember thinking, oh, I've got this. I don't have to learn a new way to do this. And if I actually worked with patients and did treatment plans the way I did 20 years ago, I can't even imagine the outcomes.
Well, and I'd be so bored.
Exactly. I'd just be pressing buttons and doing testing.
Yeah,
That'd be about it. So, and since you've had your practice, quite a long time at this point, how do you define a high performing clinic in your opinion?
I think a high performing clinic is one that is meeting patients' needs and actually just really helping patients, which is why we go into the profession to begin with. But I think that it's so easy to get distracted and bogged down by all the other things that are going on, especially today in today's climate of just a lot of there's just a lot of interruptions. And so I think a high performing clinic is one, that's meeting those patient needs. For me, I thought I was doing that. I think it's easy to deceive yourself that you're doing it. And I'm learning that that's one of the areas where I'm constantly striving to get better and better at figuring out, am I really helping people?
Because I think sometimes all of us fall into this, I know myself included, that you feel like you're doing the right thing and you realize I'm really doing this for me, not for the patient. So I think one of the best advices I ever have been given is to meet the patient where they are, rather than try to force your wants and needs on where they need to be, because that's so easy to do.
It's so easy to do. Yeah.
So tell me.
It's so easy to think that you've got all the answers.
Isn't it, though? I mean, we are the quote unquote experts, if only. Yeah. They are the experts of their experiences in themselves. I have to always remind myself and my staff of that. Now, you do something very unique within your practice, and I know because I have gone through your course and highly recommend it for anybody listening. So tell me a little bit about the CogniHear program that you do.
So CogniHear came out of a talk that I did in March of 2020. 2 weeks later, everything shut down.
Great time to do it.
I know, right? I did a talk for, I'm a part of the Entheos Cooperative, and I did a talk at our member meeting, really this ear to brain approach that I've been working on for about 5 years. And for me, it wasn't like, oh, I'm this cognition expert. It was more like, I think of it more like the periphery, the ear, and central, the rest of the auditory pathway. And I think because I started talking about cognition, doing some work with CogniView early on, kind of got pigeonholed into this cognition piece, which is just a part of it. But I did that talk about our auditory system is not just our ears, and we have been ignoring as audiologists a huge part of the auditory pathway for far too long. And so I did that talk, and I was shocked at the response of colleagues who are like, "Oh my gosh, we want to know more." And that encouraged me to, you've got to teach people what you're doing and what you've learned. And so that's where CogniHear came from.
Yeah, I think I loved it most because we all knew the research, out of Johns Hopkins. We all understood that. But it was always thrown at us as more of a scare tactic. And I didn't want to represent it that way to my patients because I didn't want to scare them into buying hearing aids. That's not really a great look or a great feel. And I think you really break it down to make us able to explain it in a way that patients can understand, that we're educating, not scaring. So I commend you on that.
Yeah, it's I don't even talk about dementia. I don't even talk about the John Hopkins studies unless a patient brings it up and asks. It's really an audiological approach, because cognition and auditory processing, cognitive processing and auditory processing are just a part of hearing and the auditory system. And so
I think we overlook it for so often when you've got somebody who's got great discrim and quiet, great, thresholds that should be easily to fit, and they're failing miserably. And you're thinking, well, why? And for so many years, I'd be like, well, they're not trying hard enough. They're not wearing them every day. They're not doing this. And in reality, their brain just couldn't take in that information.
Right.
So
I
so
always was blaming things on the patient.
Yes.
I've done that so many times. Like, I did another talk this past year on, it was titled PETA Patient or Poorly Fit.
Yeah.
And it was, I'm not going to say what that stands for if you don't know, but I was blaming it on the patient. Like they were just a pain in the push. And come to find out, I was programming the hearing aids in a way that was distorting to that patient. And then we do that because of their cognitive or auditory processing changes or whatever it is.
Yeah. I mean, there's so many facets. It's so silly of us to just think the ears could just live alone in this vacuum and that's all we have to work with. So anything that helps us enlighten the patient, enlighten our own knowledge is amazing. So what is the one thing that you believe your clinic does better than so many other clinics out there in the world?
Well, I definitely think I love neuroaudiology, that whole central piece, from that synapse with the cochlea on up through the brain, and really addressing those changes that come from peripheral hearing loss, from aging, from concussions, from neurological deficit disorders, Parkinson's, MS. That's always that what's happening as it's going up to the brain. What's the brain doing with that information? That's what I'm always wondering.
Yeah, and it's once you start thinking that way, it's so much easier to do our jobs. I had a gentleman the other day talking to him like I am you, saw no inclination of any issues. In his history, of course, he fails to mention the big things. And did CogniView, did horribly, get everything in the moderate range. And I'm thinking, oh, maybe it's a one-off. So I just start discussing the results with him because his, testing and noise was really disastrous. And he goes, oh, no, that all makes sense to me. I said, okay, explain why. And he said, I had a stroke about 6 months ago, which talking to him, no idea, none whatsoever. And he failed to mention that small piece of information during his history. And it all made sense at that point. But had I not had that backing me to ask those additional questions, we would have probably been set up for failure.
Because people think it's just ears.
Right.
So why would he tell you he had a stroke? Right. So unless we start having that conversation that hearing is ear to brain and it's very neurological. It's so sophisticated. It's
and then just the cognitive fatigue component. I mean, it's huge. Huge. It explains the fall risk, which I never understood before that component. I was like, that makes sense now.
Yeah.
All's coming together. So in your time as a practice owner, what would you say is the biggest mistake you've made on your journey?
How long is the podcast?
You can just go on and on.
I mean, seriously, Nancy, I was thinking about this question, and this more than any of the others, I just started writing down, and then I'm like, oh, and then there's that. Oh, and then there's that. Oh, and this, and this, and this. Because of course, it's like I can think of all my failures, because that's how we learn.
Yep.
So there you go. I think if I really honed it in on one thing, it would be I take things very personally.
Mm-hmm.
I'm an emotional, sensitive person. I don't think most people would guess that about me. They've met me. Um, and I am a people pleaser,
Mm-hmm.
and I don't set boundaries. And as a business owner, you with people you work with your patients, um, just for yourself, you've really got to set boundaries and know who you are and be confident in who you are and know you need to grow and know you're going to make mistakes. But um, I think that's been my biggest mistake up until now. And maybe that comes in your 50s, like you're just like, okay, I finally know who I am and this is it. And I'm not going to let you walk all over
You
me.
get
And
what you get at this age.
yeah, I am who I am, but I don't let, it was very hard for me, to not allow patients to manipulate me.
Yeah.
And now I'm just like, hey, no,
Yeah.
nope, that's not okay. Um, and that's so important because I can't tell you how many times I've cried in the bathroom at work. Over like, darn it, I bent over backwards. I did all these things. And in the end, I got treated terribly or I was accused of things I didn't do.
Mm-hmm.
And I think I would say to a young business owner that will 100% happen to you.
Mm-hmm.
And you just have to know you did the right things and stand by that and be okay and say, you're not my person, you're not my patient, and that's okay.
Yep. Yep. One of my favorite sayings I kind of have stuck by as I've aged and I've had my practice 21, 22 years, something like that, is I'm not ice cream. I can't make everyone happy. I just can't. No matter how hard I try, there's always going to be somebody dealing with something outside of my four walls of my office that's going to affect their interaction here. And you got to let it go. Especially too, as you know, you mentioned you're growing and you're hiring people. Hang on tight because that gets even more fun trying to set boundaries because you want to be kind and you want to be
Yeah.
empathetic, but you still got to keep the ship afloat. And that can be a struggle at times.
And especially as a small business, right? You're like, well, I don't want to be a big corporation. I don't want to put, everybody in this box and
Right.
everything be so black and white. And I want there to be some flexibility. I want to have these relationships. And if you don't set the boundaries, they will. That's what.
And there will be none.
And there will be none. And
you'll be in the bathroom crying more.
Yeah. And then it's hard to shift that and it's hard to get that back if you haven't been the leader. Yeah. I think one of the things that I'm learning still is when I get frustrated with how things are going, I get frustrated with the staff, with part of my team, is saying, all right, what am I not doing as the leader?
Yeah.
Am I leading? Am I being the leader? And the answer is usually no.
Yep. Yep. If I'm frustrated with something they've done, often if I've learned to take a moment, take a breath before I react and look at, okay, did they know how to do this? Just because I've talked about it, if I haven't shown them, that's on me. That's my fault. And I've got to take ownership of that. And that's not an easy lesson to learn.
Yeah.
Type A
Or
business
just
owner.
not giving clarity or thinking you've given clarity because you've said something.
Mm-hmm.
But you didn't, it's not clear to them.
Well, and I think too, as practice owners, we're in the role we are in because we tend to be fast learners, fast changers, fast adapters. And not everybody we hire is going to be that way. And I used to get so frustrated. Now I've learned we have a weekly meeting. I've got to repeat something at least at that weekly meeting for 5 or 6 weeks before it sinks in, where I'm used to, if I said it once, why aren't we doing it? And I had to learn that's not how everybody learns. I wish, but that's not the reality.
Yeah.
Yeah. So I just make sure I keep repeating. So we've covered your top worst decision. It's not really a decision, but it's hard to be empathetic and kind and still be the leader. But what would you say your best decision has been made in the time you've had your practice?
I am going to say finding my spark.
Mm-hmm.
And that happened, oh gosh, I mean, it's really what set my path on looking beyond the ear. Many, many years ago, I watched a talk on YouTube, and it was Nina Kraus in, I want to say, when she was in Denmark speaking, probably at an Oto conference or something. And I watched it. I was sitting at home, and I had like my mail next to me, and I'm just writing all this stuff on the back of my mail, because that's what was sitting next to me. And it just lit something within me. And it was like, yes, yes. And that kind of set my path. And through the years, I lose sight of that spark of what really excites me in audiology. And believe it or not, research always brings it back.
Mm-hmm.
So whenever I'm just like, oh, I can't do this anymore, or I'm stuck, honestly, you just have to pick up some cool research, and it's so it's like, research is so cool. The things that the researchers are looking at, and there's such a huge gap between what we know from research and what we're doing in the clinic, that just really gets me excited of, oh, why aren't we doing this? Why aren't we know so much more about it. So I think really finding that spark so important, because you're going to get kicked, and you're going to get kicked, and you're going to get kicked some more.
Mm-hmm.
And if you don't have a spark and a passion for something in this field,
Yeah, it happens often. You kind of go through ebbs and flows of I love what I do and I hate what I do.
Yep.
I think it's another misconception. I see it all the time on the Facebook pages out there for audiology of people looking for a career change and they're 1 year out. I did the same. I mean, I went and took a test to go work at Verizon, and then they told me, we have a job for you. And your pay went by your education. So I was going to be at the highest pay rate. I'm like, great. A job I don't have to think too much about. I'm thinking I'm going to be at a call center. They wanted me to climb poles. I'm like, okay, I might need to get passionate about audiology again, because nothing about my 411 self is climbing that pole to change wires on telephone poles. So everybody goes through that. So if you are a new grad, keep in mind, just wait another day, take a breath. You'll probably be in love with it again. And I'm going to need to require you, Heidi, to write me your Cliff Notes versions of all the research, because I just go blind trying to understand it all. So if you just send me your Cliff Notes, that would be fantastic.
We call them Heidi notes. Yeah.
Perfect.
I do that. I would say that to new audiology, you got to do some reading or watch stuff, or listen to this podcast, whatever it is.
Right. There's always something to be learned.
Yeah. And if you haven't found it, keep looking.
Right.
Be curious.
Well, and I think I've never stopped taking courses. I mean, I took yours, I took Angela's with APD. I didn't intend to add that to my clinic, but the knowledge alone has helped me treat patients better.
Sure.
Get them in the right direction. So it's not even something you have to be passionate about, but the more you learn, the better you're going to be. I guarantee that.
Sure. For sure. I mean, even cochlear implants, like, you don't have to do cochlear implants, but you should learn as much as you can about them so that you know how to talk to patients about them.
Right. And know the candidacy, because that changes all the time. I mean, when I first graduated, candidacy was you had to be stone deaf, no hearing aids could ever help you. And that was that.
I think there's still people who think that's the candidacy.
Right.
Not. And some of our patients can be, and I find it so interesting too. This is a little off topic, but patients will come in and they'll go, oh no, I'm not ready for that. Or I don't want that. And then you're like, okay, well, let's talk about hearing aids. And then now it's always about be curious. And I'm like, tell me about that. Tell me why you don't think it's for you. They're so misinformed. Their perception of what it is so different, and it's my job to educate. So,
and there's always that surgical fear, and I'll say I understand that, but you can at least go get a consultation done to have all of your information to see what your best path is. Absolutely. Now, part of your class, I know at least that was when I took it, the beginning, you talked about your why for this, and I believe it involved your journey with your son. Would you mind sharing a little bit of that? Because I think, as audiologists, especially as parents, That's why I've added tinnitus and things like that, because I couldn't bear to sit and look at a patient and go, there's nothing I can do to help. And really, there's no one else around that doing either. So tell me a little bit about that.
Yeah. So my why for never giving up and constantly seeking to be better is my son, he's now 20. He was 3 when I asked his pediatrician, when do we start worrying about OCD? And my pediatrician laughed at me. And I felt really I'm a people pleaser, so that was a problem. So I was like really embarrassed. I didn't want to be that kind of mom. And when he was 6, he came home one Friday, and he's making this weird noise as he walked by. Okay, he's 6, whatever. And he kept doing it. And finally, on Saturday or later that night, I said, Hayden, what are you doing? And he goes, what? And I go, what is that sound? What are you doing? And he goes, oh. And I go, yeah, what's that sound? And he goes, I'm counting to 3 as fast as I can. 1, 2, 3, 1, 2, 3, 1, 2, 3. But it was coming out like, and I'm like, okay, weird, but you're 6.
Right.
By Sunday, we were driving to our friend's house for dinner, and he's watching a video because it was a long drive in the van, and he's making that sound. And I'm like, Hayden, knock it off. Oh, yeah, okay, Mom. And then he kept doing it. And I looked at my husband and I said, he can't stop. He can't stop. And so we counted, and he was doing, I can't even remember how many a minute. And then he goes, well, you've always kind of wondered if he had OCD. And all of a sudden we started writing all this stuff down. And it was so obvious. It was so obvious. He had OCD, probably had Tourette's. And then we were on a whole new journey that our pediatrician didn't help us at all. And we were kind of on our own. And if you think audiology is not perfect, mental health is really...
Oh, it's really bad.
Really the wild, wild west. And just really trying to find him help. And oh gosh, I have so many stories of like just professionals who don't know what they're doing and say they know what they're doing, or
I find they just assume they're the expert.
They assume they're the expert and they don't. And so for me, I don't want to be that for other people. They are counting on me. And, his condition is chronic, and chronic conditions, I will tell you, chronic diseases don't just impact the patient, but they impact the whole family. And we are counting on his therapist to help him and to help guide him. Now he's an adult and we're counting on him to actually do the things. That's another story altogether.
I've got a 19-year-old. I get it.
Yeah, it's really hard, but I need to be better. I need to be better for my patients. So I think that's when your first question of what's a high performing clinic, it's one that's actually helping people. That's where that comes from, is we've really struggled to get the help that he needs. And that's not right. I think we constantly have to be getting better. We need to be serving patients who have who has hidden hearing loss, auditory processing problems because they have peripheral hearing loss. We need to be helping people who have tinnitus and hyperacusis, and it can't just be, well, this is the best that we've got.
And like, you just got to figure it out. You can't do that.
And we need to be getting better.
Right.
In this field, because it's chronic and it's debilitating and it's painful.
Well, I think there's nothing worse as a clinician to sit in front of a patient. And I don't know how clinicians, as you mentioned, some of your sons who just go, this is the best you can do without looking further. If somebody comes in and says they're devastated by their tinnitus and they're saying, well, the doctor told me just to get used to it. And I thought, how can you watch this person who's crumbling in front of you and just say that there's nothing that can be done? when maybe you just don't know. And yes, there are other things. So that's just always stuck in the back of my mind. And your story, it kind of solidified that when I heard it, and it's stuck with me.
Well, one of the things that my son has always has said a lot over the years is he feels such a sense of hopelessness.
Mm-hmm. And our patients feel the same.
And they feel the same. And we have to give them hope. You're working with somebody who has a chronic disease, and you're going to be working with people who struggle with some hopelessness, because the best that we can do might still be really debilitating. And so we have to constantly be striving to get better so we can give people more hope.
Right. And guide and help support them in whatever that journey looks like, even if it's not with us. I had somebody the other day came in for their third hearing test because they weren't believing the results. They had 2 others elsewhere and were told their hearing's perfectly normal, which was not inaccurate. Basic hearing test was perfectly normal, but I went ahead and put them in noise, and I did AZ Bio just unaided with normal hearing and just said, how do you do? 50 decibels, delivery, 45 dB background noise. Should have been easy. I've sat and done it myself, made sure I could do it. Yep, no problem. And the train went off the tracks. And I said, I suspect you might have some processing issues. I don't do that here, but here's somebody who does. And I referred them out. And they were so grateful, even though I didn't really do anything, but just giving them the guidance to the right direction. It's just
giving them the hope.
Right.
And affirming. And that's,
you're not crazy.
That's the other piece. My Hayden feels like, you don't understand, there's something wrong with me. And he has so much shame, so much shame. And so I think that when you finally identify why am I having this problem? When you affirm that and you identify why that's happening, and it's like, oh, no wonder. Okay, it's not that I'm stupid, and it's not that I'm lazy. It's that this is hard for me.
Yeah.
And you finally pinpointed where it is. So, gosh, even if it's just identifying why it is that you're having a problem is so important. Yeah, that whole your hearing's normal. Great news.
Yeah, good news. And they look devastated by it. And you're like, what's going on? And I've had men sit in front of me, blue collar, hardworking men in tears when I say, well, looking at your hearing loss, you probably feel like you're hearing, but maybe things are mumbled. And you're trying to focus on the word you missed. And by the time you get that word, you've missed everything that came after it. And that's when you wave the white flag and just smile and nod and hope to go along to get along. And you see them light up like, oh my God, she sees me. I'm not crazy, because their family's just getting angry at them, which I understand that too. It's frustration, but yeah.
Another key thing that I really like talking to patients about is you're working so much harder than other
anyone
people
in the room. Yep.
And that's very emotional, because you finally filled that with, oh my gosh, somebody has, like, I am.
Yeah.
Or they don't even realize they are. And they're like, oh, now you have me realizing I'm working really hard.
I said one time to a woman, I said, you're working harder than anyone in the room. And if you go out for a night of socialization, you probably get home and go, I'm exhausted. I'm brain dead. And I said, you might chalk it up to aging, but it may very well not be. And she looked at me, she was 90 and she was in tears. She goes, I just thought I was getting old and couldn't do it anymore. And after she got her hearing aids, she felt great. I mean, she still felt 90, let's be honest, but she could feel like she was part of the conversation again.
I don't have any energy at the end of the day either.
At 52, I'm done by about 8 p.m. So just looking at everything you're doing and everything out, in the, because I know you read a lot of research in the research world, what do you think the future of our practice looks like in audiology?
I think it's really important for us to get back to the basics of audiology. I feel like our field has really gotten distracted. I think we need to get back to really learning acoustics again and applying it to what we do. I've started doing that more and more in how I fit hearing aids, and it really makes me think harder than pushing buttons and doing real ear, which I love real ear, don't get me wrong. But we have to move beyond just doing real ear. because real ear can look great and we can still be distorting the signal to the patient.
Yeah.
And we can't hear that distortion. It's not what I'm talking about. That's like we're warping the signal to how the patient processes. So I think that getting back to acoustics, I think really those that utilize AI the best will be the winners. You got to utilize AI. And I think really focusing on whole person, patient-centered care. And in the AI world, that connection, that deep level human connection is going to be the most valuable thing.
Yeah. I think we got to go back to basics too. I mean, I tell my staff all the time that no matter what crazy complaint the patient comes out with, there's truth in there. And your job, and you're going to fail them if you don't do this, is to ask more questions, because they maybe don't have the words to make sense to themselves or to you what they're hearing, but there's some truth in there and you've got to dig deep to find it.
Yeah, exactly. I'm always, what am I missing? I'm distorting this. And because the hard part is, we're only seeing what they're getting at the eardrum. We're not seeing what their brain's getting.
Right.
So I do love doing FFR, but I haven't implemented it so far with fitting patients yet. So what am I missing? How am I distorting this? How could I make this better? And really advancing how I fit hearing aids. And that's tricky.
It's not just about hitting the formula the manufacturer has chosen. Absolutely not.
No, that's for sure out. I mean, you got to do real ear first. And that's the verification, but validating that for this patient, it's working. I think that's where the art comes in and all the questions and the curiosity.
Yeah. I mean, we do something as simple as having them fill out the IOIHA at every appointment, because often they go, no, everything's fine. And I'm like, right, but you were at a 32 last time and now you're at a 15. So what's going on? Let's dig a little deeper. So it helps us validate those things when maybe they just don't have the inclination, or they're a people pleaser, don't want to say it.
Right. Well, and you talked about AZ Bio, which is like my favorite tool ever.
Same.
And it's really interesting. We haven't done the IOIHA as much as we should. We've been doing the HHIA, and they'll come, they'll have a really low, like no handicap, and for their annual, and I'll put them in the booth, and we'll do AZ Bio after we've cleaned the hearing aids and checked everything with real ear, and it looks good. And they're like, these hearing aids are great, and we put them in there, and they bomb. AZ Bio, bomb it.
Yep.
And it is such an eye-opener to the patient, because the patient didn't realize how much they were hearing visually and cognitively. That when it's just an acoustic task, primarily, still a little bit of cognition in there, they can't do it.
Yep.
And so it's such a great opportunity. It's not like I fit them poorly. It's probably the best they can do based on the severity of their loss. But it's a great opportunity to have that conversation about, you're working really hard. We can make this easier with remote microphones. Here's some strategies. It just starts a conversation that allows them to learn more about what's happening as well.
And I think for years I struggled with, somebody had 20% word understanding, getting them to understand we're doing the best we can. You're doing the best you can. And they wouldn't really understand, because it is a hard concept to wrap your head around. I mean, let's be honest. Putting them in the booth now and doing AZ Bio, with their hearing aids versus, maybe there's a 3 years old, 4 years old versus something new technology, to show them you're doing the same. Like, it's not the hearing device. And we're doing the best we can. We might want to, and then using that multi-mic and letting them see that difference. Yeah. That has been tremendous, and getting them to be allies in our treatment plan, because they get it now. They understand it because they can experience it. It'd be like buying a car without test driving it.
That's the key word, Nancy, is experiential. I think too, I think if we want to get better at auditory training and oral rehab, we need to be more experiential teachers, where we're actually doing things with the patient. We can't just tell them to do things. They don't know how. So we need to do it with them, and we need to be giving them those experiences. I think experiential audiology would be maybe the future of audiology too, is giving
I
them.
agree. I think we're so, I'm still shocked and amazed at how many people don't do any form of demo to a person when they're recommending a hearing device. Like, why? Why wouldn't you not demo it? Then that your job gets easier because then they can see and feel and touch and hear what the difference is.
Well, not only that, I'm discovering, I'm really struggling to predict what type of processing a patient would love and really does best with optimally. So I try to use as much science as I can based on what I know. But sometimes I actually have to fit them with, and let them compare it, fit them with two, or do AZ Bio and do what I think is going to work and see how they do. And if it's not great, I'm not happy with this. I don't know that I made the right choice here. Let's try something else. And yeah, it's time consuming.
Yeah.
But again,
still worth it.
I think that high performing, like that's why they're coming to you.
Right. That's why they're not going to Costco or online, because they're not going to get that. That makes us different.
And then you get their buy-in too. They chose. Yeah.
I've done it with folks that got hearing aids that were just poorly fit by another practitioner, maybe a year or so earlier. Like they're wearing CICs and they need a power BTE. We've all seen it. And in some level, I don't ever fault the practitioner if I don't know the full story, because I know some people are just adamant and demanding and that's what they want. However, when I put them in the booth and I do for AZ Bio with their hearing aids on first, and then I'll put something more appropriate, I've had people stop me in the middle and say, what are these? I want these. Because again, they're going by one thing only, the cosmetic look. And nobody explained to them differently or let them experience differently what that was going to look like for them. And that's all they need.
And then we do this.
Non-compliant.
But I counseled them. That's not enough. You have to show them how much better it is with this other.
Right. And we actually do it now every year at our yearlies, because I want to assure them that their hearing aids are working up to their maximum performance. And I want to know when that time or shift changes, when they no longer do. Yeah. And yes, it's really all that, but it's their experience day in and day out. And I want them to be able to see that, what, we're at 4 years out, might be able to consider something different. Sometimes I go, yeah, this test showed us that. And other times I'm like, no, continue on as you are. This is doing great for you right now. And I can give those honest answers.
And doesn't that give you the most credibility?
Yes.
And your patients know they can trust you. I've said that a number of times. I'm like, everything looks great. I mean,
I had a woman the other day, 8-year-old hearing aid. She's killing it. I said, here's my only concern. If these break, we might not be able to get them fixed. But it wasn't like, well, it's been 8 years, you've got to get new, because she was doing equally as well with both. Who am I to say she needs something new?
Right. And research shows that some patients don't do I can't say the word.
Magnificently
better with the new technology. And and it's usually cognition. That's, that processing isn't there. So it doesn't really matter. Or the patient's not in a lot of noise.
Right.
This is still meeting your needs. You're getting great audibility. They sound good. We've been taking great care of them. Carry on. Do
as you are. Yeah. So that's why I love that test. And I'm so grateful to have taken your course and been introduced to it, because again, I don't do it exactly the same way you do, because you have to make it your own within your own practice, but it's definitely doable. So I think people need to be less afraid of time. Well, I don't have time to do that. You'll find a way. Well,
I don't do the full 20 list anymore either.
Oh, really?
Time.
Don't tell my staff. I told them they have to do the 20.
Well, if you're really, I was like, but then we're not really comparing apples to apples, but just, you got to do what you can.
Right.
And if you got to cut it to 10.
At the end of the day, you're still helping that person. You're not recommending surgery off of this. It doesn't. That's the other thing I've gotten into disagreements with audiologists, and they'll say, but you're not doing the way the test was designed to do. And I'm like, I am not recommending surgery on this. This is just to give them the experience, to give me the knowledge and information. So it's fine. It's not that heavy.
Right. And you're comparing within the same person too.
Yeah, it's not a research paper. So looking ahead at our future, as I get towards the downward slope of my career, what would be the one piece of advice you'd give somebody who is either considering this career or new in the career for longevity?
Be curious. Mm-hmm. And I hated it when people would say that to me. Because I'm like, what does that mean?
Listen to this old lady.
Be curious about what? Be curious about being curious. No, be curious. You're never going to have all the answers.
Right. And you're never going to know everything.
So constantly seek out information. Get better. If you are burnt out, do some learning. Mm-hmm. Yeah. And find what sets your soul on fire. Because for me, it's not doing an audio.
No. Lord, no. It's the least favorite part of my job at this point in my career. That and showing somebody how to put a hearing aid in. I'm like, I'm done.
No, Bluetooth. Okay, I'm all done.
We have it set up now that the audiologists do diagnostic and treatment plans, and I've trained HISs, and they do the activations of the devices and all of that. And we work as a team because I can't do it at this point in my career. I cannot sit and show somebody how to put a hearing aid in.
I'm like, if I have to say these things one more time, I'm going
to stab myself in the eye with a fork. Like,
yeah. So be uncomfortable. Mm-hmm. And doing something different and new is really uncomfortable. And in my 50s, it's really hard.
Right. Because I don't have the ambition and motivation like I once did.
I don't know if I want to think, but you actually do, because that's really fun. So,
right. And don't be afraid, because if you're starting a new test with somebody, you're not going to be perfect the first time you do it. Absolutely not. When I started the A&L after taking your course, and the first time I did it, I look back and I'm laughing because I had no earthly idea what I was doing. And I was loud and soft and all over the place. But the patient didn't know. And
they have no idea.
Just act confident, act like you know what you're doing, and then move on. Like, it's fine.
Yep. And just hit pause and say, okay, hold on one moment. Will I set up for the next test? Okay, what the heck am I doing?
I'll be like, oh, the computer's acting up. Hold on a moment.
I just started doing auditory training therapy. Yeah. My audience she's a 6-year-old.
Right. What does she know?
You just have to act excited. Know your audience. Like, she don't know what I don't know.
Right. Right.
And you just got to do it. And one thing that somebody said to me one time that was really stuck to me, I wanted to, with this whole kind of looking beyond the ear piece of it, and how do you sell that? How do you get people interested in it? And I was thinking about it, and I was like, well, it's really about hearing in noise. That's what people want. They want to be able to hear in noise. So I'm like, I'm this hearing and noise expert. And I am. Like, that's really what I try to help people do the most. And I needed a surround sound. I wanted to give people more of that experiential, real world type scenario. And I was talking to a business advisor about it. And I said, but, that's just, there's nothing. And he said, what about just getting a surround sound at Best Buy, having it installed and doing, and I go, but to do it right, you got to have different sounds and different speakers.
Yeah, we need it to be perfect.
In that way. And he goes, well, what are other people in your community, in your area doing for it?
Nothing.
And of course it was this, and I said, well, they're not doing anything. And he goes, exactly.
Right.
So you're already doing something more than anyone else is doing.
Right.
I was like, oh.
And they're already going to notice it's a different experience when they come to you versus anyone else. Not that you got your equipment at Best Buy, but I do the same. I mean, I won't start a new activity until I have the whole outfit and then the shoes and the everything, because I have to look the part. I don't even know what I'm doing. Why do I care?
Yep.
One of the things I love, and you have it in your program, is the quote, and I'll get it wrong, so I'm going to let you do it. By Arthur Ashe. I love that quote.
Start where you are, use what you have, do what you can.
Yeah.
Do what you can, use what you have. Doesn't matter the order.
It's the same concept.
Yeah. You just start where you are, and it's not perfect, and makes you want to grow up.
Mm-hmm.
And you just do it anyway.
If you don't do it, it'll never be perfect. If you do it, you'll eventually get there. It's that theory of, marginal gains. Just do 1% better every day, and think about how far you'll be in a year. Well, I really, any parting words for us as we finish up, Heidi?
Oh, I think if we just focus on getting better for our patients, I think audiology has a bright future.
Mm-hmm.
Yeah.
Yeah,
and
I think
not
we need to
being
stop
so
being chicken
distracted.
little. We get so distracted, like the sky is always falling. Just focus on what we do it well, do it differently, and you'll be.
And being so politically correct, and we
Ugh.
don't want, it's like, I think we need to be, my team teases me. They think I should start a podcast called The Angry Audiologist.
I wanted somebody to tell me I should start one that's called, you know what grinds my gears? It'd be very long.
Oh, there's so many things I see
Yeah.
that grind my gears.
Yeah.
And I don't want to be negative, and I don't want to throw people under the bus, but at the same time, I really want to push.
Yep. Well, we need to be our own disruptors.
Mhm.
Why are we letting other people disrupt our industry? Let's us disrupt it and make it better. And that's what we
Yeah.
need to do.
Yeah. And show people how. Like,
Exactly.
hey, this is how we could be doing it.
Well, and I think, your course alone does that because, you're one small clinic in Minnesota. There's only so much you can do for your area, but you can then teach audiologists across the country to implement these same things. And that's amazing. So if somebody listening wanted to get in touch with you, what would be the best way to do that?
Oh, a great question. I should know. How to get on the
Let's pretend this is an emergency, Heidi. How do we get in touch with you?
Okay, good business owner. I think it's cognihere.com. Yeah, that's it.
And again, I highly recommend that course.
And I am Heidi at hearinghealthmn.com.
Well, I really appreciate your time today and enlightening us on all the things that you do so well and so differently than the rest of the audiology community. So I really commend you on taking that step and putting yourself out there to start teaching us what we need to know. So I appreciate that.
Thanks, Nancy. Appreciate it.